there is the Patient Revolution is an organization that is the backbone for a global movement for careful and kind care. And care requires a space, a conditions in which care can thrive. And one characteristic of that condition, of course, is trust, which allows for that space between uh, care receiver and caregiver to be transparent, to be open, to allow for that connection that enables the possibility that care can make a difference in the lives of those who give and receive care. And so trust is an essential condition for care. And so it's actually really wonderful that we have an opportunity to spend time together with great and generous speakers today, and with the participation of all of you after their participation so that we can, as a community, explore this topic together. I am delighted that you're all here, and thank you for your participation and support of the Patient Revolution. Sheila, back to you.
Thank you very much, Victor. I am so honored as well that you've all taken the time to join us today. And for those of you who will be watching the recording later, we thank you as well for finding the time to tune in to this important conversation. I am Sheila Maroney, and I'm the Executive Director of the Patient Revolution. So I think you'll all agree there's never been a more critical time to talk about trust, and especially trust and its impact on care. And we hope you're here today because you want to not only learn from our brilliant panelists, but also to take some time to reflect on your own role in rebuilding trust within the context of healthcare. So just to set the tone for this morning, I wanted to share a few excerpts from a poem that is really a call to action for today's conversation. It's a poem that is attributed to an elder from the Hopi Nation in Orive, Arizona. You have been telling the people that this is the 11th hour. No, you must go back and tell the people that this is the hour. And there are things to be considered. Where are you living? What are you doing? What are your relationships? Are you in right relation? Where is your water? Know your garden. It is time to speak your truth, to create your community. Be good to each other, and do not look outside yourself for the leader. There is a river flowing now very fast. It is so great and swift that there are those who will be afraid. They will try to hold on to the shore. They will feel they are torn apart and will suffer greatly. No, the river has its destination. The elders say we must let go of the shore, push off into the middle of the river, keep our eyes open and our heads above water. And I say, see who is in there with you and celebrate. We are the ones we've been waiting for. So I hope that that gives you some uh, food for thought as you listen to our panelists today and really reflect on, again, what is your own role in building and rebuilding trust in healthcare with your individual relationships, in the patient-provider relationship, in your role as a member of a team, as part of an organization. I think that we all have an important role to play, and I hope that you'll gain some new insights and inspiration from today. So first, let me introduce Carolyn Canfield. She is an independent citizen patient and adjunct professor in the Department of Family Practice and on the Faculty of Medicine at the University of British Columbia. She has spent the last 17 years since the unexpected death of her husband from poor medical care, striving to advance partnerships among patients, health professions, and community through teaching, research, writing, and much more. She also shares her talents and insights with the Patient Revolution community as a fellow. And she has won many awards and is co-founder of Canada's only independent peer-led community of practice, the Patient Advisors Network. Thank you for being here, Carolyn. Erin O'Malley is the executive director of the Coalition for Trust in Health and Science, a promising new organization founded in March 2023 to ensure that all people are empowered to make informed decisions for themselves, their families, and their communities about health and science. I know Erin from her role as Senior Director at America's Essential Hospitals, where she guided policy advocacy and strategy for our nation's safety net health systems, a critical piece of our healthcare infrastructure. She has 2 decades of experience in health policy and has deep expertise in strategic planning, public-private partnerships, advocacy initiatives, and public health campaigns. Welcome. Erin. And then finally, Gary Schwitzer has specialized in healthcare journalism for more than 50 years in his career in radio, television, interactive multimedia, web publishing, and academia. He was the founder of healthnewsreview.org, which published daily reviews of healthcare journalism for 16 years, including a toolkit of tips and resources to help journalists and the general public to improve their critical thinking about healthcare interventions. Gary has been recognized for his work by the American Medical Writers Association and was on the faculty of the School of Journalism and Mass Communication at the University of Minnesota. You'll find his work in a wide variety of peer-reviewed journals and other media, and we all can still benefit from his insights and wisdom through his popular and almost daily Substack.
Thank you so much for this invitation. It's really a great pleasure to join you. So I've titled this short presentation, Understanding Healthcare Through Relationships of Trust and Networks of Care. I call myself a citizen patient. I'm self-selected as not only a dependent on the healthcare system, but also a funder of public healthcare in Canada. And to me, it's an act of citizenship to participate as a partner in trying to make healthcare better. As a patient, and I'm presenting very narrowly and experientially as a patient today, there are a lot of different names for this role, for this perspective in different countries and in different facets of our healthcare system. So some of these may be more or less familiar to you. I have a lot of roles, as Sheila described, a lot of different hats. And today I really am going to stick narrowly to the patient perspective, the experience of being a patient, given Gary and Erin's points of view. So I have no financial disclosures and no conflicts of interest to declare today. There are a couple of takeaways I want to offer you. To me, healthcare is a collaboration. It's not a product. It's not a service. It's an action. It's doing. Healthcare is defined by networks of trust. So for me, improving healthcare means improving relationships. So I entered healthcare when my husband Nick died 8 days after successful surgery on his leg. It was a great surprise to his care team, and it shocked and actually devastated them. It was traumatic for his healthcare team. So it really was a train wreck at the end of post-operative care. Everything was going along just fine until suddenly it wasn't. Now, this picture in 1895 is obviously a massive disaster. But the second picture from a few days later, here are these inspectors who are all crowding around the train wreck. There was a proper, formal, elaborate official inquiry. But in my case, in my train wreck, there was no case review. There was no inquiry. There was no follow-up. There was no follow-up with me. There was no follow-up with the care team to try to learn something from this calamity. So I was alone on an empty stage with his chart, and I had no medical background. I have no professional training. I tried to put the pieces together because I felt it was important to salvage some kind of learning from whatever had happened. But there was nothing from the system. And this was really a shock to me. I felt as though the trust I had in the institution of medicine, the obsession with excellence and the pursuit of tireless pursuit of excellence really wasn't present. And that felt like a betrayal. So I put all my energy into studying everything I could. I asked for advice on what to read. And much of what I learned gradually and slowly used a vocabulary that I thought I understood, but I really found that these were in context with medical literature and healthcare professionals' perspectives. It really was a different kind of vocabulary. But what I felt tied everything together here was trust. It seemed to me that healthcare functions through trust as enabling us to deal with suffering, to deal with the unknown, uncertainty, with risk, and with putting our safety in the hands of others. And these relationships are really defined by the actors in the system. So when trust is shattered, when relationships fail, once damaged, trust is very hard to put back together. I was kind of fascinated by this unidirectional stability in trust, and I began to study it. I began to really study it in depth. Well, Canadians have very high expectations from their healthcare system, and what we call our universal healthcare system is really a big element of national pride. So when I found just a couple of days ago this very recent survey on Canadians' trust, using that word, that healthcare actors of various kinds provide accurate information. So these really high percentages, and these survey results that reflect a high trust in the reliability of information from healthcare professionals, it seems to me wasn't anything related to the kind of trust, the relational trust that I was concerned with. So this seemed like a distraction. There's lots of academic literature and lots of research that defines trust in various ways, and this is a characteristic example. Trust being the willingness to be vulnerable under conditions of risk and uncertainty, and then mistrust and distrust, looking at the failure of those relationships that provide trust, the failure of an agreement on what an expectation is. And then trustworthiness is also defined in terms of a sort of predefined acceptance of what would constitute a shared trust. Well, here's an analysis I like a little bit better. These domains of trust made a lot of sense to me, but I was really interested in relationships and what's at the heart of carrying out and embodying these kinds of relationships that tie the trust domains together. So I did find this really interesting Venn diagram. And this comes from some qualitative research about healthcare providers and what are the behaviors that build patient trust. And it was based on interviews with patients. The researchers identified 3 themes: caring, communication, and competence. And I think it's worth taking just a minute here to look at what the patients said. Caring was made up of characteristics, healthcare provider characteristics, behaviors like treats patient as an individual, commits to solving a health issue. And the communication is sort of overlaps with caring, is listening and values patient experience. The competence comes into play with communications, that the communications should be thorough and the communication should be knowledgeable. And then all 3 themes coincide with the detailed explanations that the patients expected to get as much detail as they wanted. So this is kind of useful, but I thought this isn't really the way we experience trust. So I'm going to try to take us on a very quick rapid walk through some of my ideas on trust and the absence of trust as it's experienced, and how to build trust as it's experienced. So this is what I know. So from a patient perspective, to a layperson, this place doesn't look like trust. What does it take to turn this place into trust? You've taken away my identity, my language. Your language isn't my language. When I arrive, I shed my clothes and I become, anonymous. And my care plan may not make any sense the way you explain it to me. It's only confusion. Well, The stress of illness, the distress, the disruption of everything else in my life. There may be tipping points in my experience of illness, my experience of care that are unrelated to the illness, but still affect my experience of the illness. So by joining up, by feeling as though I'm heard, this can relieve stress, even if it doesn't affect me physiologically. That being accompanied, I need to know you're traveling with me, not doing something to me. The thoroughness of communication and the knowledgeableness of communication and patient values may come into this image. What I'm looking at here is having everybody at the table to exchange and share information with clarity, to establish a common language, and to have continuous ways of updating that information. When we experience a episode in care, everything is always happening too fast. Things are changing more quickly, and it's hard to tolerate the confusion without a translator or a guide to help us cope with the change, especially as things evolve and become more serious. We also really benefit from having an expectation that seems familiar, so that when we do arrive there, we recognize some guide points. It may be best or even only possible that this is provided from people who have gone through the patient experience before us. So having patient peers help us interpret what expectations are likely. How could we recognize what this experience will look like as it evolves? Well, who is this patient? Where do I belong? Who's most important in my world? These are the connections that really matter to me that I bring into that care experience. Those people I care for and the people who care for me. This is where I draw my strength. So identifying and including trust and connections for everybody in that network that I, as a patient, bring into the care experience really demonstrates your understanding of my belonging. So in these pictures in the upper left, there's some Aboriginal teenagers in Australia. Lower left, some older Japanese women in a community center in Japan. In the upper right, there's a family sitting on the couch with this dog that plays an enormous role in the life of this family, as the kid in the pink shirt is going to experience some really difficult health encounters that will affect the entire family. The dog may be the key to enabling that family to stick together and to survive well. And in the lower right, it's neighbors. Our healthcare systems are really oftentimes designed around patient and family, when a huge number of people don't have that built-in family member at hand to be our caregiver, to assist us through the experience.
Carolyn, just as promised, the 5-minute time check.
Okay, that's great. One of the mottos that I learned in community organizing many years ago is strength in diversity. And I believe that this plays a really important role in building trust relationships in healthcare by recognizing, respecting, and offering dignity for that and celebrating that diversity that connects us across ways that we might not expect. And that these relationships can be among the most powerful in our experience of care, both as patients and as providers. So how does this happen? Where is this done? Well, this is how. This is where trust is generated, and this is where it's cultivated. How do we do this? What kind of techniques can we use face-to-face in direct relationship? Well, a number of years ago, with some educators in the UK, I helped develop some questions for undergraduate medical students. So people who didn't have any medical knowledge, but really wanted to have some meaningful interactions with patients. And we developed this Ask One Question format. So what can I do to improve your care today? Opens up, it's an open-ended question. It opens up a conversation, and it may address needs, but it's only the beginning of a conversation. These questions are meant to be easy for a patient and a professional to engage in that conversation. And the most important part of it, of course, is listening, asking the open-ended question and then listening. So the next one, what's the best you think you can be? This may get open a conversation about goals of care, goals of life. It's important to listen to award agency, to award respect and dignity. What's one thing you wish you'd known? That's a lovely way of asking about gaps in care. It's a way for providers to identify what's missing. What's one thing you wish you'd known in advance from a patient perspective? What's one thing that made a difference is also a way to ask about assets. What are we doing right? What's one thing I should know about you is a beautiful way to open a conversation where the patient feels comfortable to express values. Now, the idea of starting these questions of what's one thing is planned to be to make life easy for the patient. If you ask, what are your values, or what are your goals of care, or what are your needs, it's really difficult. Like, I can't sort them out. I've got too much on my mind. I'm not sure. I'm not sure if that's the most important or there's something else if I just thought about it some more. But if you ask what's one thing, it takes the pressure off and the conversation can unfold in a natural way. So here is where these conversations can happen, these beautiful open-ended conversations at the speed of the relationship, the speed that the people need to take. And it can happen in every setting. Knowing you're connected allows you to have real care. You're fine-tuning the relationships through communication, honoring the dignity and respecting the way in which the patient wants to engage. This visual metaphor, it seems to me, places the two paths of the patient and the care team in the right kind of geographic setting, the landscape. So together we've decided on what the reward is. What are we aiming for? What's at the end of our path? We've been able to together identify some risks. We've also been able to identify what's unknowable, because there's lots about medicine that's uncertain. And we know that science is evolving, that we don't have all the answers today, and we'll never have all the answers for this person. So the question is, who leads the healthcare team? And the answer pretty clearly is the patient always leads, but we travel together. And I'll just finish off with a quotation from a favorite Canadian sociologist who writes, "At clinic at the bedside, the system is people touching each other. Everyone affects that person's healing and affects the remoralization of medicine or the demoralization of medicine. In the moral moment of that touch, there is no system." So thank you very much, and I look forward to our discussion and questions later.
Thank you very much, Carolyn. And that was really inspirational, beautiful, and so heartfelt. And thank you for making yourself vulnerable to all of us through your experience. So next we'll turn to Erin O'Malley. Thank you, Erin.
Sure, thank you. Thank you to the Patient Revolution team. Thank you, Carolyn. It was a perfect setup, thinking from the patient, the immediate provider relationship, as well as juxtaposing the Canadian healthcare system. So I am pleased to be here today on behalf of the Coalition for Trust in Health and Science. As Sheila had noted, we were formed back in 2023, largely coming out of the COVID-19 public health crisis and pandemic, and out of concern about both the declines in mistrust and distrust that have been unique to the American healthcare system from the beginning, but really came to the surface during the pandemic, as well as the evolving information ecosystem that can leave patients, as well as those of us in the health and science space, vulnerable to a lot of mis and disinformation. So let's see, make sure I can move my slides. Here we go. So a little bit more about us. It is our vision that everybody is empowered through evidence-based information, accurate information, to make personally appropriate health decisions. How we are doing this is, as noted in our name, we are a coalition. We have just about 100 organizations who span the entire health and science ecosystem. They are trade associations, nonprofits, societies, foundations, who represent the health and science ecosystem. So from individuals who are in biomedical labs doing research today, to public health officials of all stripes, to providers and various healthcare facilities of all stripes. We are pleased also to have payers at the table, bio and pharma industry representatives at the table, individuals with bioethics responsibilities, and rounding out the entire ecosystem with organizations representing patient advocates and consumers. We very intentionally put this big tent together, recognizing we still have some gaps. We're not covering every single aspect of the health and science ecosystem. So would love to speak to anybody on our line today who feels as though you're not represented within this context. We have some gaps and would love to fill them, and are actively working to ensure we have all parties together so that we can work together, recognizing, and I'll go into this in more detail, that as Carolyn so articulately put it, especially with those graphic images, it is so important for one-on-one patient relationships. However, we do recognize that a loss of faith and trust in science can erode those individual relationships and change how individuals engage with the system. So we work collaboratively. We are constantly trying to help our members learn and evolve, as well as to push out timely evidence-based resources. So what this looks like actually in practice, we are committed as a group of 100 national organizations to do 3 points of engagement or activities together. So one is promoting and sharing accurate, understandable, and evidence-based information. Another is strengthening trusted messengers to effectively communicate evidence-based information. And then, I'm trying to move my screen around. And then third, empower people to make those personally appropriate health decisions that are connected to their values and goals. It's really important to underscore the fact, and I'll talk more about this throughout my time with you, that we recognize that, especially from a public health, healthcare delivery, professional side of the equation, if you will, that our values are not always aligned with those of the general public. And I think back to a now becoming classic example in the context of COVID, where public health officials, healthcare delivery wanted to save as many lives as possible. For many individuals across the country, their priority was to ensure they could keep their businesses open, that their children could go to school in person. And so we are now in a moment where, not just with that one example coming out of COVID, but we know that the values of the field, if you will, and that of some individuals across various populations are different. And so we're working to figure out how do we better align those values. So what is at stake? This is somewhat overly simplified, but we do know that if you trust the system, and again, that system is your immediate doctor, your nurse, your pharmacist, but it's also the entity who you access care from, the either public or private payer that is the catalyst for the coverage of your care. It is public health officials in your neighborhood, as well as at the national level, who are pushing out information. So, when I think of and talk about in the context of this slide, trust in health and science, I'm at that really big picture of all players in the context of the health and science ecosystem. And when that trust is there, we know that there's a higher uptake in utilization and preventive care. We know there are better outcomes, including those actually reported by patients. We know that resource allocation is better than when there are gaps in the context of resource allocation. Effective public health campaigns can thrive, as opposed to a breakdown, as I was noting, in values, where the two go in opposite directions. And our public health campaigns are not actually changing behavior. We know that with trust, innovation and progress can happen. And, this is an example in particular. There are public policy pressures that are putting pressure on how people trust the system. And if you're not trusting, in particular, biomedical innovation, research, clinical trials, and from a public policy perspective, you stop funding them, you dismantle the infrastructure, we will not have innovation and progress. And then, of course, and I think, Carolyn, you've very well painted this picture for us, with trust, you will have a stronger patient-provider bond. The other side of the coin here is that without trust, we know that we're bound to see underutilization of services, especially preventative services, poor adherence to both medical advice as well as an ability to achieve optimal outcomes. We will, of course, see increased misinformation. And I know Gary is going to speak from an even higher level about the information ecosystem and how that influences trust. We see, unfortunately, without trust, an overworked and a demotivated, demoralized workforce. We will see widening health gaps, and we'll see wasted money. One of the things that, especially in the context of misinformation and the proliferation of influencers, we see a lot of individuals who will say, don't get this vaccine, don't engage with your healthcare provider, pay money to me, buy my supplements. This will protect you and your family. It is wasted money and it's wasted hope. So moving to our next slide, a note on trustworthiness. We rarely, even though it is in our title, only exclusively talk about trust. We've really changed our language and our emphasis to focus on trustworthiness. We know that trust is incredibly nuanced. We know that if you take an example like vaccines, many people will be placed into the pro-vaccine or anti-vaccine camps, where the nuance lies when you actually start to talk to people who are skeptical of vaccines or have questions about vaccines or hesitant. They might be okay taking a vaccine as an adult, but don't want to give it to their child. They might be okay with any type of vaccine as long as there's no mRNA technology. So peeling back the layers of the onion to recognize that, in particular, where trust is lost, it is incredibly nuanced, and it's not one size fits all. We know that trust is lost in gallons and regained in teaspoons. And a really important component for us, and this is really the core element that brought us together, is recognizing that one party alone can't fix this problem. So often I hear, if we only gave doctors 10 more minutes and a code to bill for effective communication, trust in health and science would be fixed. End of story. And we move forward. And it's not that simple. And it's not fair just to put the emphasis and onus on one part of the system. If you don't trust your insurance carrier or provider, that will help you lose trust in the system. If you don't believe public health officials when they speak to you, that erodes your trust. That'll change how you engage with the healthcare system. And we just established why trust and lack of trust and how those two play out. We do recognize, especially because we have this big, diverse coalition of members, that the elements of trustworthiness are different between a pharmacist and a patient or consumer, a physician and their patients, a public health official, the manufacturer of a vaccine or new medical device. It is different for bioethicists as they think through and engage with the public. But a clear through line that we're really honing in on is the emphasis of communication. Effective, trustworthy communication is one, we very firmly believe, one way to ensure that we can get back to rebuilding trust, establishing trust where it needs to be established, and maintain it moving forward.
Erin, the 5-minute,
Yes.
5-minute
Thank you.
notice.
Thank you. So how we go about our work, we have two core pillars. First and foremost, working through those trade associations, societies, the members within our organization to educate professionals in the field. And again, those are professionals of all health, public health, scientific stripes. We, on a biweekly basis, bring the best and brightest case studies and examples through our Learning Lunch series. We have a series of professional-facing, evidence-based resources on our website, toolkits, wallet cards, one-pagers, most of them really honing in on communication-related tactics and actions to take. And then finally, opportunities like the one that we are engaging together on today, speaking about our work at conferences and on podcasts. Second big pillar of our work is really getting down to the individual level, helping individuals figure out really what you could call health literacy, science literacy 101. How do you access and why is accessing evidence-based information so imperative for your health? We revamped our website. We've done a town hall event and hope to do more. And we really see our public-facing website as a great place for individuals to go to learn about the scientific process. How do you read a scientific paper? So my final slide here is really honing in on a big component of our coalition's work this year, which has been listening. Listening is imperative in any relationship, but especially the one that we're talking about today. And it matters more today than ever. Both very publicly as well as behind the scenes, we've been having conversations, in particular with communities who are skeptical of health and science, who have different views than the mainstream establishment, if you will. And so what we are finding is that a very clear common ground, regardless of where you sit, if you are a professional in health science or public health, or you are an individual, you believe that the approach that you're taking is one that is evidence-based and that is the best thing that you could do for your family. We go down different paths sometimes from there, but that shared common ground of, I believe firmly I'm doing what is best for us. So we encourage our members, especially those that represent the professionals in the field, to listen more, to lead with curiosity, to name those shared and common values. And again, Carolyn, I love that one of those questions that you had up there, getting to, what is the one thing that you value? And of course, leaning into the nuance of science, which is very hard to do, while acknowledging that we don't have all the answers all the time, that there is a lot of risk and potential benefit in the work that we do, and really leaning into the importance of today more than ever, especially in this media ecosystem with so much information coming from so many different directions, that evidence is important and what evidence looks like related to science today. So thank you again, and I really appreciate the opportunity to move into a group conversation.
Thank you very much, Erin, and we really applaud your efforts to pull together this big tent and hold it up. It's going to take a lot of stakes to keep that afloat, and we're really appreciative of your efforts. And what was interesting to me about these two presentations so far is the word vulnerability showed up a couple of times as emphasizing making ourselves vulnerable to one another in terms of enriching, trusting relationships. So thank you again. And now Gary. Gary, you're muted.
Thank you. For my entire 50-year career, I've worked at this intersection of two professions that really depend heavily on trust from the people they serve, and that's journalism and biomedical science. In both professions, I've seen how it takes years to build trust and then just fleeting moments to lose it. These days, we are flooded with a tsunami of messages on social media, algorithms feeding off of our habits and then pushing us into echo chambers of one-sided information. Way too much advertising, podcasts, talk shows, concerns about AI impacting the veracity of what we read. With all that, I can't do justice to all of this in my allotted time, but since I'm a career-long healthcare journalist, I'm going to start with that sector. And before I get into any problem areas, I want to emphasize that I think some mainstream news organizations have been simply outstanding in this tumultuous time of upheaval in our federal health agencies, in health policy, and in the public dialogue. But when you come down from those mountain peaks of excellence into this daily drumbeat of dreck, as I call it, you find a lot of journalism about healthcare that may lose readers' trust by being out of touch with the real needs of news consumers and healthcare consumers. And here's that listening theme again that Carolyn and Erin touched on. Many journalists may not be engaging with and listening to their audience. There's a fascinating podcast series called Why Should I Trust You?, which over the past few months has featured a series of listening sessions with MAHA followers, Make America Healthy Again followers, who often distrust science, meeting with public health and medical experts who are behind the science. They are the science. I think this is a great model for journalists to build trust with the readers and viewers and listeners that they serve. So I polled more than a dozen journalists from all over the country about whether they knew of any news organizations that have held such listening sessions. Nobody had. Several agreed it was an interesting idea, so maybe I've planted a few seeds. But even though there aren't any obvious listening examples to point to, there's starting to be some attention given to this general idea that journalists need to engage and listen better. I found several embryonic efforts among national and international journalism organizations, but I'm going to highlight just one of them. And I'll go to my slides now for that. So there's an interesting project called Trusting News that's trying to inspire journalists to evolve their practices in order to actively earn trust. So Trusting News teamed with the Center for Media Engagement at the University of Texas to test and promote the idea of journalists using explain your process sidebar boxes, putting that alongside their stories to get at things like why and how we're covering this, how we took steps to be fair or complete, how we chose whom to interview. This could help the public gain trust in journalism, understand the process of journalism. You can imagine how this could be employed with healthcare on health policy stories. But then just in the past couple of weeks, I've seen a couple of things from the New York Times that I think are a good early sign. There was this article, How Do Times Health Reporters Choose Experts? A few basic guidelines help us ensure we're finding and interviewing the right sources for health and wellness. So that's only one example. And then there's this one, which is, well, it's not related to healthcare. Inside the Times reporting and judgment calls on Charlie Kirk's assassination, we gathered some of the journalists closely involved to discuss how we approach coverage and to answer readers' questions about it. I don't recall seeing much, if any, of this kind of thing in the past. So this may be a good sign with the Times being a leader on this. So this is a wallet card that we used to give out to journalists and to the public, anyone who would listen, with the 10 criteria that we used on my Health News Review site that I published for the last 16 years of my professional career. We graded 3,200 news stories and PR news releases applying these 10 criteria, looking at stories that included claims about healthcare interventions. So these are the kinds of stories that can inform healthcare consumers, but they can also confuse, mislead, or simply be inaccurate. So this was, this is a list of the things that we learned over 16 years, showing the huge potential for journalists to lose trust and perhaps damage the trust in science and medicine when they did the following: emphasize or exaggerate benefits while minimizing, ignoring harms, publishing single source stories, often with conflicts of interest in those interviewees, failing to disclose conflicts of interest, which, by the way, I didn't say that at the top. I have none to disclose. failing to disclose the limitations of research, for example, with observational studies or surrogate endpoints, conveying certainty where it simply does not exist, disease mongering, which means exaggerating the seriousness or prevalence of a condition, often by reporting patient success stories, often patients who are handpicked by public relations firms representing drug industry interests. Assigning healthcare stories to journalists who aren't trained in evaluating evidence, and publishing way too brief 200-word stories on complicated topics. Each of these represent easy to correct flaws that fail to provide news consumers what they need in healthcare stories. But remember, these are really difficult times in the journalism industry. They're looking at financial troubles, reduced newsroom staffing, story quotas calling for several stories a day from each staffer delivered in different media formats, print, audio, photos, video, digital. And with print circulation down, broadcast audiences split among competing ideologies, panels and debates and loud shouting filling time on 24-hour networks. The idea of hosting listening sessions may not be a very high priority. But it's also important to separate which media messengers we're talking about. I got to tell you, my skin crawls when I hear people complain about the media. Journalists are different than talk show hosts, which are different than social media influencers or bloggers or Substackers or podcast hosts, some of whom are journalists, but most are not. There aren't any ethics codes for these non-journalistic media voices, yet they all get lumped in together under the umbrella of the media says, the media are unfair, the media have a liberal bias, all of which are unfair and inaccurate if you're lumping all of these media types together. So now I'm going to transition to a couple of examples of wildfire spreading on social media. This is an interesting article published recently in the BMJ Evidence-Based Medicine, a content analysis of Instagram and TikTok posts concerning 5 tests that are roundly showed to have strong potential for overdiagnosis and overuse. So they looked at 1,000 posts that had something like 200 million followers. And here's what they saw. The whopping majority mentioned potential benefits, the whopping minority mentioned any harms, and only a few mentioned potential overdiagnosis or overuse. But almost 70% of those who posted had a financial interest, a dog in the hunt. Half encouraged viewers to take action and get the test. A third featured personal anecdotes, and very few showed any evidence. Here are a couple of examples of how ivermectin false claims spread like wildfire this year. One social media influencer with 600,000 followers on the X platform called ivermectin a cutting-edge cancer treatment, cited anecdotal stories of alleged success treating cancer with ivermectin and other parasitic drugs. No evidence was given, just anecdotes. And in 4 days, that influencer's posts were reposted 4,000 times, got 11,000 likes, and were bookmarked 6,100 times. Let these numbers sink in. Another example. Some accounts with large followings have promoted dimethyl sulfoxide, an industrial solvent and byproduct of paper production, as a miracle cure for a range of health issues, including cancer. They often portray past regulatory restrictions on this substance as evidence of a deliberate suppression of an effective treatment. This is that old, they didn't want you to know about it claim. One X account with more than 1.8 million followers described this combination as the 50-year-old cancer miracle hiding in plain sight, and said the FDA chose to bury the evidence, which simply was not true. Other accounts also presented unsupported claims about DMSO as a cancer cure as evidence of a conspiracy, including one with more than 300,000 followers claiming that the FDA banned it because despite knowing that it cured cancer and made chemo more likely to work.
Gary?
Yes.
5 minutes.
Okay. Just last week, after President Trump delivered the false claim that the Amish don't have autism, one influencer on X posted a clip of Trump's remarks to his 600,000 followers. His post gained almost 2 million views and 19,000 likes in 24 hours. And then one podcast example, one is enough. Joe Rogan had Mel Gibson on, spreading the story of three friends with stage 4 cancer whose cancer disappeared months after taking 2 anti-parasitic drugs. Again, no evidence, just stories, 11.5 million views at least. And then on another podcast, Gibson said he'd gone to a Panamanian clinic because of a shoulder injury and lung damage from years of smoking. He claimed he was now completely healed. Again, no evidence, just stories reaching millions. So what can you do about any of this? Some of these I don't have good answers for, but if you see things in journalism that you know are wrong, are inaccurate, as an individual, as a member of a group, a university department, a patient group, an advocacy group, let that news source know when they're inaccurate, not evidence-based, not balanced. Write letters to the editor, ask for a meeting with the op-ed department. That's how many of these opinion pieces you read end up in the paper. Encourage your local news source to host listening sessions like those Why Should I Trust You? MAHA listening sessions. Share that explain your process sidebar idea, which I love, with your local news source. Learn how to, or help others to, learn how to evaluate evidence. If you use social media, stick to evidence-based sources and evidence-based statements, not anecdotes. And then use this app called the 5 Calls app as an easy way to contact your elected officials. It's really an easy on-ramp. You enter your zip code, they will give you back the phone numbers and email addresses of your federal, state, or local officials and topics that you may want to weigh in on. Also, look for some of the trusted sources who are now using Substack as a very vibrant platform. The NewsGuard reality check, an ER doc named Jeremy Faust, the epidemiologist Caitlin Jetalita, another epidemiologist, Gideon Meyrowitz-Katz, who goes by the health nerd, Jess Steyer on unbiased science, Kristen Panthagani in the You Can Know Things site, and then just 3, I think, outstanding journalism examples. Stat News, which is behind a paywall, but a pitch, I think it's worth it. ProPublica and KFF used to go by Kaiser Family Foundation. Now they go by KFF Health News. Excellent on health policy news. And a spinoff from that, on the KFF website, is this really interesting initiative, the Health Information and Trust Initiative, which is a very good source of polling data and articles about these issues. So thanks a lot for your attention. And I look forward to getting into this discussion with you and hearing your thoughts and suggestions and ideas.
Well, thank you so much, Gary. And along with the other 2 panelists, you have given us hours worth of potential conversation and dialogue with one another. And particularly, I really appreciated the last couple of slides that help us each think about what is our own individual role. And again, we'll share these slides with all of you. So if you weren't able to capture that long list of great resources and the resources that are referenced throughout the chat, we will compile those and share them with all of you.